I'm Maxim Chumak, Dr. Maxim Chumak from Fort Lauderdale, Florida. Name of the clinic is Hair by Dr. Max Restoration Center. Today I cover a very important topic in hair restoration, how to achieve more with less. In recent years, we have a tendency of moving towards mega and giga procedures. It became a sort of a trend. I fell into the same tendency previously, and I was trying to perform 4,000 grafts, 5,000 grafts, over 5,000 grafts in one day. Because what you see on social media sort of creates this type of urgency. If you're not doing this, you left behind. And then over time, I started to realize we can harm patient more than we can achieve. If everything goes well after 5,000 or 6,000 graft case, yes, it might help. But what if we have a complication and all these grafts that have been harvested will be lost irreversibly? And what I started to investigate is how we can achieve more using less grafts. And there's a lot of tricks, a lot of techniques that we can improve the cosmetic appearance without using too many grafts. And by the way, this one of the technologies I've been using is TrichoLAB, because TrichoLAB can give an ability to precisely measure the donor area, precisely measure the recipient area, and to show what both can look like after a certain quantity of graft being extracted. So when I explain to my patients everything that we can achieve using TrichoLAB, this is the best method to educate patients and for me to get the precise information so I can plan accordingly. With preservation technique, we are frequently able to achieve similar results with just a fraction of grafts. And I show some examples in my practice where I was able to get similar results that compares to 5,000 to 6,000 grafts restoration using only half of this quantity. Thank you so much for the invitation. I'm really glad to be here, Dr. Mihir and Dr. Trivellini. So my topic today is actually how to try to achieve more with less in hair restoration. So it's sort of the opposite what we're going to be talking about mega sessions today. So I have no conflict of interest to declare. And so my discussion will concentrate on mega sessions and whether we need to really invest into performing as many grafts as possible. Because mega and giga sessions recently became sort of an ambition for many doctors, and social media is overwhelmed with all these images about how many grafts we can implant in one session, 4,000, 5,000, 6,000 grafts. And we do know that obviously mega and giga session can carry higher risk of complications, especially in inexperienced hands. So we have a perpetual problem. Recipient demand always exceeds the donor availability. In advanced donor with 6 to 7 patients, the original loss can exceed 20,000 follicular units, and obviously we cannot substitute it one-to-one as a replacement. So the question is, how can we achieve more using less grafts? So we can approach this problem in 3 ways. First, we can improve graft survival, so more of what we harvest can actually grow later. Second, we can optimize visual density, so the same number of grafts create greater cosmetic impact. And the third, we need to concentrate on treating miniaturization due to androgenetic alopecia, and hopefully we can reverse some of the miniaturized hair follicles into terminal form. So any surgery starts with good ergonomics, and here you can see I'm using a wall-mounted microscope which allows me to work comfortably during the entire procedure. Optimizing graft survival rate, three things are very obvious. We need to make sure that our assistants are doing everything to prevent mechanical injury. So using two-point contact with the graft and handling it by a safer area is very important. Grafts experience metabolic stress immediately after extraction, so we need to maintain stable temperature, continuous hydration, and minimizing the time outside the body. It's really critical to preserve viability. So you can see here we're using electronically controlled system which circulates weak alcohol solution and maintains the same temperature, about 8.5 degrees, throughout the entire procedure. Optimized storage solution, it's a topic on its own. It's a long topic, but some of the options we do have is liposomal ATP, hypothermosol solution, which can reduce cellular stress and can support better healing later. In my practice, I use platelet-poor plasma as a storage solution with addition of ATP, since we perform two PRP treatments, both to the recipient and the donor areas. And something very obvious, so it's important to arrange your grafts in chronological order. So the grafts that come out first will be reimplanted in the beginning, and so on. So as you can see in our plate, we have 4 chronological groups, and when we start the implantation, we use this particular order. So one of the methods for donor preservation, especially in patients with previous procedure in depleted donor area, is controlled FUE splitting under high magnification. And you can see here, it can help to preserve the donor area. So something that not frequently discussed is actually that the outcome of the surgery is not only being determined on the day of the surgery, but is determined during the first 7 to 10 days after the surgery. And if we think what we can do to remove this guesswork and hoping that everything's going to happen and the patient's going to be okay with neovascularization, or we can do something about it. So what I learned by using HBOT, medical grade hyperbaric oxygen therapy, that we can actually support neovascularization by stimulating CD34 progenitor mobilization and VEGF. And this is well known and described in multiple articles in literature. It's probably the only treatment that has an immediate impact on neovascularization. That's how we heal diabetic ulcers that failed any type of treatment for many months, and then we can see it in front of our eyes how everything happens. So the next category would be, how do we optimize visual impact? This is where the plating geometry, direction, and graft selection, which allow the same number of grafts to create greater perceived density. So it starts with using, in my practice, TrichoLAB. TrichoLAB can objectively measure density, shaft diameter, miniaturization, allowing us to plan the graft use more intelligently. Using TrichoLAB, we can simulate density redistribution when we concentrate higher density in higher follicular unit graft anteriorly, and even with the same total graft count and overall appearance improves more significantly. TrichoLAB also allows us to calculate average hair caliber and map regional variation, so the coarse hair can be placed where the bulk is needed and the fine hairs where softness is required. So here's an example of the donor area mapping. You can clearly see there's a big variation between different zones of the donor area, and we can use it to our advantage to plan proper distribution of grafts. So what about donor area? How do we use it to our advantage? Once we created a map, as you see it in the previous slide, you can use the coarser hair in the frontal area, and the areas inferior in the donor area are the most stable. So they're there's less perspective that they will undergo miniaturization in the future, so we'll utilize it in the frontal area. So density should not be distributed equally. The frontal third always dominates perception. So the highest density and the highest value grafts belong anteriorly. And while greater compromise can be accepted in the mid-scalp and the crown area. And here, just an example, how much impact we can have just moving the starting point of the hairline 1 to 2 centimeters posteriorly. And the example is really obvious. Just by moving 1 centimeter more posteriorly, we can save about 700 grafts. But the visual impact is really minimal. So instead of 7 centimeter from mid-glabellar line to the start of the hairline, I would start with 8 or 9 centimeter. Now, where the placement geometry matters, linear rows allow visible light corridors. A staggered or brick pattern configuration interrupts those gaps and improves optical density and with the same graft count. This is actually a concept was borrowed from Dr. Vissam Farjo. He had a nice presentation about that. And this is some of the slides that can show what happens when you change from linear to staggered pattern. And you can see with the staggered pattern, there's no light penetration. And it's actually very easy to perform. All you have to do, you just implant grafts right in between of the previous row for the entire time. So what about exit angles? If we look from the top of the scalp, the old method was to place grafts at 90 degrees angle, right? What if we decrease angles to 15 to 20 degrees or even 10 degrees? In this case, the shaft lies over the scalp surface, increasing overlap and projected coverage. True density does not change, but visual density will improve significantly. And here's where we should question the dogma. Looking at the textbook, the suggested angulation of different zones is like that, 15 to 20 degrees anteriorly, 30 to 40 degrees anteriorly. But what doesn't really matter? What if we do 10 to 15 degrees everywhere? I don't think it's going to impact your naturalness, but you will definitely see better coverage. So this is something when we talk about optimization medical treatment. This is, well, some of the slides are borrowed from Dr. Pablo Serino, who combined 6 sessions of CRT or microinfusion of dutasteride and finasteride with 5,500 of FUE hair transplant. You can see the results are probably comparable to about 10,000 grafts hair transplant. So it is definitely one of the options that we have. And here's another example of same coming from Dr. Pablo Serino, but using the CRT technique with patients without the hair transplant. So it's always a good option to start something non-invasive and achieve as much improvement as we can before we go into surgical correction. SMP was mentioned previously. SMP is one of the easiest ways to augment our results. So here's an example of a patient with only 2,800 grafts who had a hair transplant, 2,800 grafts with Norwood 6, but then we got a few sessions of SMP, and you can see it's pretty, for the amount of grafts that we transplanted, 2,800 grafts is pretty good. Here's another patient with 27, almost 2,800 grafts as well, Norwood 6, and the results are comparable to 5,000 or 6,000 grafts, at least using all the techniques that we just discussed. Thank you so much for your attention. And I encourage everyone to participate in the upcoming ISHRS Congress in Rio de Janeiro. So I hope to see you there, everyone. Thank you.